Again, thanks OR UK for hosting this. Thank you FRCS Mentor for hosting this, and both of you guys for inviting me today. If you're happy, I'll just get going. Is that all right?
Yes, please.
Awesome. Okay, just going to share the screen. There we go. And just checking that you can see the title slide.
Lovely.
Perfect.
Can see
okay.
it perfectly.
Okay. Just. Okay. Well, so. Thanks again for inviting me. So the main purpose of my talk today will be to look at timing in orthopedic surgery in the bleeding patient. I think as well, what I'll probably spend a decent amount of time today is talking about some basic principles. We'll talk about shock and the response to bleeding, why bleeding is actually still difficult to diagnose and can be difficult to diagnose, the response to injury. What do you see on your blood pressure, heart rate monitor, etc., that can give you an idea of the level of injury that's happened? We'll talk about coagulation, and then we'll talk about SIRS, which often gets mentioned, but there are other things as well. And then we'll talk about principles of resuscitation, and then we'll talk about damage control resuscitation, damage control surgery, early total care, early appropriate care, all these weird concepts and terms which basically revolve around a package of intervention. But I'd like to highlight now that actually there's a talk by a friend of mine, Pete Bates, who did one a couple of months ago, which is on the OR UK website, where he's also talked about orthopedic polytrauma management. And I definitely recommend that you go listen to his webinar as well. So let's talk about the basics. So this is the problem that you have in your trauma bay, in your emergency department, or can have. And this can happen at a major trauma center. Most of the time these days, that's where it is. Occasionally it can happen in a district general, but less often, but still a big problem. So we need to think about what's going on here, what's happened, and how we can treat this. So often in my pre-hospital care hat on and with my pre-hospital care job, this is what I'm often going to, this kind of level of incident, polytrauma, significant amounts of injuries for usually multiple patients. But what governs everything that's going on in terms of how the body responds to trauma and trauma physiology? And this is a big part and an important part of the FRCS exam and an important part of the FRCS syllabus within the trauma chapter. And the whole thing that governs trauma physiological response is inflammation. Hence this funny electron microscope artistic picture. It's all about inflammation. It's stuff that you would have heard and seen when you were at medical school. It's the same thing. So we've talked about response to bleeding. All of you, I'm presuming, have done the ATLS course. So you'll all have an idea of the ATLS classification of shock. Class 1, class 2, 3, and 4, that revolves around how much blood an individual has lost. And it's usually bracketed in percentage blood loss. So class 1 shock, usually they lose less than 15%. In class 2, it's 15 to 30, etc., etc. If you need a good way of remembering this, just remember tennis scores. So 15 love, 30 love, etc. And then that gives you a way of remembering the percentages. And then the general issue is that the pulse rate goes up as you lose more blood. Yeah, sure. Blood pressure gradually goes down. Pulse pressure initially increases, then decreases. Pulse pressure is the difference. Respiratory rate is the only thing that always goes up as you lose more blood. So there's a couple of things. So ATLS has a very nice table that explains it. If you get this kind of question in the Viva, they are looking for this kind of answer. You talk about percentage of blood loss, severity of shock, and what you'd expect to see in the patient. But I wouldn't necessarily worry whether they'd actually ask for individual numbers. So I don't think they'd ask you for a respiratory rate in class 3 shocks. I wouldn't worry about that. Just know broadly that certain things go up, like heart rate, and certain things go down, like urine output and blood pressure. Importantly, though, in real life, the issue is that everything is not quite as simple. So when people have assessed the ATLS classification and kind of looked at it in clinical reality and how useful is it really, the problem is it's actually found wanting. It's not really very clinically useful sometimes. You can have people with excellent heart rates, maybe 80, 90, and you could perceive that's not too bad. You can have people's blood pressures are seemingly okay. So, you know, blood pressure of 105 over 80 in a very small, petite person may seemingly be okay. So there's lots of issues, and we'll discuss why actually ATLS the classification system doesn't work all that well. There's a phenomenon as well. Some of you may or may not have seen this in patients with significant amounts of blood loss, either due to blunt trauma or penetrating trauma. And those of you who've seen patients who've been stabbed in the chest, who've had significant bleeding from the heart or the lungs, for instance, they are frequently very bradycardic. They don't mount any kind of tachycardia at all. Or if they do, it's very mild. You won't see heart rates of 140 in these patients. They'll all be 80, 90, and suddenly they'll become bradycardic. The blood pressure is usually maintained until the last minute. I highlight this article here just as a case report because I find it amusing that things like this get published as case reports when actually things like this were actually very well understood back in the 40s and 50s. And even in the Second World War and the First World War, people knew that if you had blood loss and you were bradycardic, that was an imminent sign that you were about to arrest. So what's going on? So the issue is that actually the body is not silly and the heart is not silly. So when you are losing lots of blood, it would be foolish for the heart, for instance, to continuously become tachycardic more and more, because that would effectively mean the heart needs more blood supply, more metabolites. It needs more blood to then take away all the waste products of metabolism. And the problem is that they're in a shock state. That's totally not what you need. You do not need an organ to force or to continuously require more and more blood, because that just makes the situation worse. Actually, there are multiple systems around the body, and I've just highlighted 3 of them, that actually detect significant amounts of blood loss, either due to pressure issues or pH issues in the blood. And they then stimulate the autonomic nervous system to reduce the heart rate and gradually reduce the blood pressure as well. Because the heart is not silly. It doesn't need to keep asking for more blood flow when there isn't any to go around as it is. Okay, so when you have significant amounts of blood loss, your heart rate will actually, it might go slightly tachycardic, but will actually become bradycardic. And there's an evolutionary response to trauma as well. There's lots of issues around leaky capillaries, and I'm kind of stepping into ICU level territory here, but it's important that we as orthopedic surgeons understand this. So with trauma, the capillaries become permeable. Yeah, so all your tiny blood vessels become permeable. And so what that allows is, it allows, if you follow the blue boxes, it allows white cells to go into the interstitium of the organs, and it allows fluid to go from the extravascular space, i.e. from the interstitium, and allows fluid to go into the intravascular space. So effectively, the body is trying to replenish the intravascular volume by sucking out fluid from the interstitium. This helps increase your volume, increase your central venous pressure, and helps to keep cardiac output going. So that's what the evolutionary response is. But the problem is that we continuously keep wanting to give people fluid and more fluid and more fluid. So we're actually fighting against a response that's been trained over generations. So by giving fluid, you actually then force fluid to go from the intravascular space into the extravascular space. You end up getting edema in the organs, and you then get organ failure. So this is a big problem, and this is why we've gone away from using a lot of crystalloids, because it's just not very good practice. It causes a lot of problems. And we definitely have gone away from using colloid, because colloid elicits a huge inflammatory reaction. So we've gone from the days of giving hex starch or other simple components. We've stopped all that and tried to stop using saline as well. So I told you earlier, 2 slides ago, that if you lost a lot of blood, you become bradycardic, your blood pressure will go down, etc., etc. But I know for sure that you guys have seen, and I've seen, patients with significant amounts of trauma have a significant tachycardia. So the way to think about this is, if you look down the middle here in the black writing, these are typical numbers you will see on any monitor. Systolic blood pressure, heart rate, respiratory rate, and obviously GCS you measure. So these are what your patient exhibits, the external features that you can measure, their parameters. You then need to split their trauma into 2 things: the level of bleeding and the amount of injury they've had. Okay, and when I talk about injury level, I mean the amount of tissue destruction they've had. And when I talk about bleeding, I just mean pure blood loss. So the responses of these two are very, or can be very different. And it's how the two combine that leads you to have these funny numbers in the systolic blood pressure, heart rate, or rest rate. So if you are bleeding and from a simple stab wound to the heart, for instance, blood pressure would be maintained for a while and then would be suddenly hypertensive, go off a cliff into arrest. Bleeding, you get a very mild tachycardia, and then your heart would go bradycardic because your heart knows you haven't got much blood, so it's going to slow itself down so it doesn't have to work too much because it knows there's not much blood to go around. Your rest rate becomes tachypneic because your lungs are still trying to get rid of excess CO2, etc. And your GCS reduces. Okay, so that's very straightforward. Now, if you didn't have much blood loss, but you had like a really nasty injury, so you had a massive crush injury, but you didn't have any significant blood loss, you would actually become a little bit hypertensive. Your heart rate become very tachycardic because this is a noxious stimulus. So your sympathetic system is super activated. Your hormones like adrenaline from the adrenal cortex and from neuron endings are all being released. So you become tachycardic. You also become tachypneic. So you start breathing harder as well for different reasons. And again, your GCS falls and reduces. So how these two, the bleeding combined with the injury, how those two interact is actually leads to what you see on the blood pressure. And that's why sometimes with someone who's had a massive injury load and also a lot of bleeding, their systolic blood pressure looks vaguely normal. And their heart rate might not be that bad. But when you look at them, they're white as a sheet because they've lost so much blood. And so this is why it can be difficult to diagnose blood loss. So coagulopathy, so this is a really interesting topic I find fascinating. Interestingly, most of the research for coagulopathy in trauma is all being done by general surgeons, mainly out of the Royal London, or trauma surgeons out of the Royal London. Not a lot of it has been done by actual hematologists. So anyway, so there is a coagulopathy in trauma, and it's not to do with loss of factors, not in the early stages anyway. There's 3 perceived mechanisms. We'll talk about those in a second. You all know the lethal triad of death, which is coagulopathy, hypothermia, and pH. If you have these issues ongoing, you will increase your mortality risk. And the issue mainly is around hypothermia. And the lower your body temperature goes, the less effective enzymes work. And so your coagulation cascade doesn't work that well as well. And also you become more acidotic. And again, that doesn't help the coagulation cascade. So lots of problems here, a vicious cycle. So the lethal triad. And it's when we talk about coagulopathy in trauma, different terms are used: acute traumatic coagulopathy, trauma-induced coagulopathy. They're all roughly looking at the same thing. In terms of, I'll just pop back for a second. In terms of the 3 mechanisms, I'll touch on it a little bit later, but there's 3 things that people believe happen in coagulopathy. 1, you don't form the clot properly. 2, your fibrinolytic system that's responsible for breaking down the clot, so that's the negative feedback loop, that becomes hyperactivated. And that's where tranexamic acid comes in, because it works by inhibiting fibrinolysis, so helps maintain your clots. And the third is there's a problem in the expression in the endothelium, so platelets don't work that well. Yeah, so 3 mechanisms. Platelets don't work, fibrinolysis overactivated, and the clot that you first form is not that good quality for some reason. Coagulopathies are interesting things. So if you think about this, you actually do want a little bit of coagulopathy. Again, this is another evolutionary response. If you're hypovolemic and you've lost a lot of blood and you don't have medical care, what you're effectively going to is a low flow state. So your body slowly pumps the blood around. It doesn't do it too fast because it knows that you haven't got enough blood. So it just sends it around. But the problem is, if you have not that much blood, your body will probably want to start to clot this blood because there's not much of it. It's moving very slowly. There's a bit of stasis going on. So you start to get some of the features of Virchow's triad, where you eventually are at risk of getting a DVT or some kind of little clots. So what does the body do to avoid getting these little clots everywhere, like the muscle or the gut? It basically makes the blood coagulopathic so that it's extra thin, And so it doesn't form these little clots. So again, it's all an evolutionary response. And we in trauma care are totally messing with it. But we have to do something, because not everyone would survive if we just left it to nature. So as I said, this is the three mechanisms by which we currently believe that coagulopathy works, or coagulopathy occurs in trauma. Activation of protein C pathway, so you don't get a proper formation of thrombin in the clot. Hyperfibrinolysis, so excessive breakdown of your clot, and so this is where tranexamic acid works, and platelet dysfunction. So there's a really interesting thing about inflammation. I won't spend too long because this can be super boring. Effectively, most of you would have heard about the first and second hit. So you have something called the systemic inflammatory response syndrome and the counter anti-inflammatory response syndrome. And effectively with this, and people have believed this for a long time, you get trauma, that's the first hit, and you mount a systemic inflammatory response syndrome. And people used to say that if you then did significant surgery, so this could be a second hit, and effectively you could get a SIRS response all over again. And this could effectively then place the patient at risk of death. What people have actually found to be the case in reality now is that you have a SIRS, systemic inflammatory response syndrome, and the counter-regulatory system, so that's the red and green, actually both activate at the same time. How long they're activated and how one balances the other is a lot to do with genetics and individuals and groups of people. And also some of it is to do with how we then treat the patient. So if we end up spending a long time operating on them and give them some kind of a surgical insult, then they're at risk of prolonging their SIRS response and getting problems like multiple organ failure and edema. I'll skip over this one. The next couple of graphs are just to show some interesting things. This graph basically has been looking at resuscitation in trauma patients in London about 6-8 years ago. So it's got a little bit of old data, but it shows you, well, it will depict what I want to show, which is that as patients have, when trauma patients are admitted, as opposed to minor injury patients, but polytrauma patients are admitted, and as you start getting increasing blood transfusions, 4 units, 8 units, 10 units, your coagulopathy profile gets worse and worse, okay? So something to bear in mind. And this is why massive transfusion protocols have been recommended, and why certain protocols have the components they have. And we can talk about that later if anyone wants. Also important to note that once you start having huge amounts of transfusion, either when you're in hospital, and over time, your mortality risk increases. So this is your mortality risk in hospital in 1 month and 1 year, if you've either had 4-unit transfusion, the gray box, or a 10-unit plus transfusion. So you can see once you've kind of gone over 4 units and you're near 10 units of blood transfusion, your mortality rate increases significantly. And look at this, at 1 year, there's still people dying, and we don't really know why. Interestingly, lactate, all of you would have heard about lactate as an important marker for shock. It can take ages for it to fall. So look at this group of patients. So they had a lactate when they came in at 10, they were transfused, and even by 1 day, it's still like 2.5. At day 3, it's still probably 1 to 2. So lactate takes a long time to go away. In terms of the principles of resuscitation, I mean, the modern setting for resuscitation these days happens in pre-hospital, in the pre-hospital environment. So at the scene with the air ambulance service, and as I say, this is the service I used to work for a while ago, and now I switched to a different one. And so they start your emergency medicine resuscitation. They start your ATLS at the scene, typically going to gunshots or stabbings. This is a cyclist who got run over by a dumper truck. So they start all of that in the field, and it's important that they do that because it still takes over an hour to get a major trauma patient into a hospital, even in London when there's 4 trauma centres within a few miles of each other. And so the pre-hospital service do start all that to begin with at the scene. So we'll talk about some important components now. So damage control resuscitation. So what I'm going to talk about now is basically concepts. It's not a thing, it's a concept, okay? So that's the key thing to remember. Damage control resuscitation is mainly for patients who are actively bleeding. So they come into your hospital, into your emergency department, they're still bleeding. The aim that you need to bear in mind is the team needs to achieve hemostatic competence, i.e., you want to get the patient's blood to behave normally, transport oxygen, and be able to clot properly. So you want to get it hemostatically competent. You want to achieve early hemorrhage control via surgery and/or interventional radiology. You want to do something called permissive hypertension. It's called permissive hypertension. It's called different terms these days, resuscitative management, or lots of different terms. But basically, it's when you let people have a slightly lower than normal blood pressure in order to stop massive variations in their BP that may dislodge a clot. And the target of your BP, we'll talk about in a moment. You want to limit your fluid infusions, so don't give crystalloids, and you want to target any coagulopathy. In terms of permissive hypertension, good numbers to remember just for your young, fit adult is if you've got an isolated head injury, you want a systolic BP that's pretty near normal, 120. You need to perfuse the head at all costs. If you have polytrauma with a head injury, you can aim usually for around 100. And if you have polytrauma with no head injury, you can let the systolic BP be lower, okay, so 80. Okay, so these are reasonable numbers to hang your hats on. As we said, we want to limit fluid infusion, so avoid excessive crystalloid, because it worsens coagulopathy, increases hypothermia, and doesn't actually treat the blood loss problem. You want to activate a massive transfusion protocol. And for all of you guys who are sitting the exam, I thoroughly recommend you have a brief look at your own hospital's major hemorrhage protocol, major transfusion protocol, or code red protocol, or whatever it's called, just so you're roughly familiar with it. And honestly, it's not that hard. It's basically usually a sheet of paper, one side. And effectively, it says something along the lines of a senior member of the trauma team must declare a major transfusion or a code red or whatever the term is. If a patient's BP is less than 90, they don't respond to some initial fluid resuscitation, and you suspect ongoing or active hemorrhage. And then with that, you get a number of things. You get some packs of blood to begin with, and that's to ideally fill the patient with blood. And the packs that you then get later are the packs that contain coagulation components like FFP, platelets, and cryoprecipitate. Other things that we can frequently see used are Celox gauze, which is a hemostatic dressing that you'll see people stuff into wounds. Pelvic binders, important for pelvic injuries. And you should think of pelvic binders as a resuscitative instrument, not a mechanical instrument for orthopedics, but rather it's important for hemostasis. You can have splints to manage people's femoral fractures, tourniquets occasionally used pre-hospitally, and again, large dressings to stop the bleeding. Tranexamic acid used very often, given pre-hospitally, and another dose is usually given in hospital, and we don't really want to be using this. Saline or Ringer's lactate, etc. We want to get people to the CT scanner as soon as possible. And then after that, we want to decide what their problem is. So either they go to surgery, they go to, which is the top left, they go to interventional radiology, the bottom left, or they go to intensive care for more supportive treatment, which is the right-sided image. You'll occasionally hear about things called thromboelastography. I won't spend too much time on this. Basically, it's a point of care blood test where you take a sample of blood off a patient, you put it in a special machine that basically whizzes the blood round and measures how fast it clots and then how long it takes for that clot to then disappear. And then from that, you get various pictures and numbers that will then tell you what the problem is in the coagulation cascade. Is it that you don't have enough FFP? Is it you don't have enough platelets? Is it that the platelets don't work, et cetera, et cetera? And then you can do targeted coagulopathic management. Now, other things that you'll hear about is early total care. So this is defined as fixation of all fractures in the first 24 hours. All fractures is a very variable term depending on which paper you read. But it was shown for a long time to be associated with reduced rates of fat embolus, ARDS, organ failure, and VTE, so venous thromboembolism. Our main proponent started from a chap called Bone in 1989 from America, and then it got used a lot everywhere in mainland Europe and here in the UK, and also ongoing in America. And then in 1999, Hans Christian Pape began to show that there was high mortality in multiply injured patients if you had operations that took a long time. So if you had operations that lasted long, mortality went up. So they decided, well, I think what we should do is something called damage control surgery, and that's when you had damage control orthopedics, etc., or the whole concept of damage control come about. And in damage control, the aim is to control your hemorrhage, manage your sepsis, protect yourself from further injury, and restore the physiology and minimize the second hit. And in reality, the principles are for orthopedics, it was using a lot of X-fixes. So you wanted to do stage treatment. You do some resuscitation in the emergency department. You X-fix all of your fractures. You go to the ICU, you leave the patient alone, and then you take them back to theatre when you convert them definitively to their definitive treatment. So be that IM nails or plates. And that can be anywhere from a few days to a few weeks' time. However, shoving X-fixes on everyone wasn't a great thing and has its own problems. And so over the last decade, there's this phenomenon, the new one called early appropriate care, which is somewhere in the middle of early total care and damage control. And so this effectively says that you should aim to do early total care, or early appropriate care in this case, once your patient has been appropriately resuscitated. It recommends trying to do that within an 8-hour time frame of resuscitation. You want to meet your physiological targets, so get your lactate less than 4, your pH better than 7.25, base excess less than -5.5. So effectively, you want to bring your lactate down and try and get your patient not to be acidotic. Yeah, and that's usually managing people with blood transfusion, massive hemorrhage protocol, etc. Now, in that 8-hour time frame where you get to resuscitate them, if things are getting better, then you should aim to get them to theatre within 36 hours to fix their long bones. So there's better outcomes, and this has been shown continuously by Heather Vallier in all of her papers from 2010 to 2017. And there's less complications. This is in elderly patients and in young adult patients. The question is, what are long bones? So previously, in early total care, a long bone used to be considered as humerus, forearm, femur, tibia, etc. But actually, if you dial down, and from Vallier's work, it actually is spine, pelvis, acetabulum, and femur. So these are the 4 long bones. You'll realize that only one of them is actually a long bone and the rest are just bones. So pelvis, acetabulum, spine, and femur. And the main reason you want to do this is that by fixing all of these, patients can then be nursed better in ICU. They don't have log rolling restrictions. They don't have pelvic rolling restrictions. They can be sat up. They can be sat out in a chair, and their respiratory physiology gets much better. They don't get things like ventilator-associated pneumonias and other problems. So that's the thing that a lot of us are kind of gunning towards, early fixation of the long bones. So overall, just to kind of wind it up, your rough pathway through the emergency department for your given patient coming in, you have an unstable bleeding trauma patient, okay? So you want to think about damage control resuscitation, damage control surgery potentially. These are concepts, right? With damage control surgery, you want to limit the hemorrhage. So if there's any active bleeding, you want to stop that. And that could easily be something from the spleen, the liver, or from the peripheries, an arterial injury in the leg, or even potentially in the pelvis. And we talk about that if anyone wants to. Manage any sepsis, so clean any wounds, protect the patient from further injury, correct the physiology, so that's ICU's job really, and traction and cast for the low limbs. And then for damage control resuscitation, we've talked about permissive hypertension, hemostatic resuscitation, i.e. give them blood products and blood itself, manage and fix the coagulopathy, and avoid the lethal triad. So keep them warm, don't let them become acidotic, and don't let them become coagulopathic. Or if they do, try and fix these. Patients then go sit on an ICU while all of this is happening. They gradually recover, and then once the timing is right, you then take them to theatre, ideally in the first day and a half, 36 hours, for early appropriate care. Okay, so in summary, we've kind of gone through quite a few things: so trauma physiology, the principles of resuscitation, and then talk through some of these concepts. And I definitely would recommend you go listen to Pete Bates' webinar on the OR UK website, especially as he spends a lot of time talking about early appropriate care. Right, thanks very much. I'll stop screen sharing now.
Lovely, thank you, Ash. That was a fantastic presentation. Thank you very much. Are you okay if I run the MCQ questions now? And then I'll let you know. I'll share the results. You can talk us through the answers. Bear with me just a second while I run the poll. So if you can all please kindly attempt these. As per usual, your answers are all anonymous, so please have a go. We'll give you a couple of minutes now just to complete these. Thank you.
Thank you, Ruth. Just a reminder to everyone, OR UK is a charity based in education and research for orthopedic related conditions, including arthritis. Their website has a lot of basic videos and a lot of other courses and so on. We do strongly recommend you to visit them. You might find a book or course that you like. Also, the FRCS mentor group, the group that's, again, charity-based. We're trying to make sure that education is available at this level for FRCS as much as possible. Visit us on the YouTube channel or on our webpage. And also, we have courses as well for you guys to join. I also want to plug our book as well, Concise Orthopaedics, behind my head there. We do think it is worthwhile. You can get it on Amazon and all online booksellers as well. Thank you. Please do answer, because if only a small percentage of you guys have answered, then you're not getting good feedback as to how you're performing or how we are performing.
I'm just waiting till we get to something like 60–70%, and then I'll answer, and then I'll go through.
Yes, I'll give them another minute, people to answer. It won't be much longer.
I'm loving Schwann's bookshelf, though. I'm very envious.
Yeah, I purposely set what I'm kind of worried about is that my taste in literature is being kind of exposed up at the top.
I can't read the stuff at the top. I'm trying to.
It's better you don't, actually.
All right. Okay, so I'll start talking about it now, if that's all right. There's about 70% now. Just
let me just end the polling, and I'll share the results with you.
Thanks.
So you should now be able to see how people have voted. Can you see that okay?
Yeah, totally can see that. Okay, so the first question was, which parameter is most appropriate in determining severity of bleeding and hyperperfusion? All right, so hyperperfusion is basically shock, right? And so we've already said, and just from kind of MRCS level, lactate is the best thing for looking at shock. I'll go through why the others don't work so well. So HB less than 100. So yeah, if your HB is low, then effectively, yes, I guess as a surrogate marker, you're saying that there's not enough hemoglobin. But the problem is you'll find that a lot of trauma patients don't have very low HBs to begin with. Even early on in the first few hours, HB does take a while for it to really equilibrate and give you an accurate reality, or give you a real level that's appropriate for that patient. So it's falsely reassuring if you were to look at HB initially in your trauma patient. Urea and creatinine, again, they're not really appropriate to use as a blood test to look at hyperperfusion. I mean, they will be very elevated if there's renal hyperperfusion, but it's not a good accurate one to determine bleeding severity. CRP is next to useless. I'm glad no one opted for that. Coagulation profile. So coagulation profile, yeah, so the traditional coagulation tests were designed by hematologists to use as blood tests to monitor coagulant profiles like warfarin. INR was invented for warfarin. APTT was designed for heparin. And so using a coagulation profile for trauma doesn't work that well. And so that's why we have things like TEG and other profiles. But so overall, lactate is the appropriate answer for that one. Next one, which vessel is the most commonly injured in pelvic ring injuries? Now, I haven't really touched on this at all, but the answer is actually the superior gluteal. That's the commonest one. It's one of the first branches of the internal iliac artery. Now, if you get an MCQ question and they give you two options, they want the correct, most accurate one. So you could kind of argue the case that internal iliac is potentially correct, but no, the most correct answer in the list of options you have there is superior gluteal. And then the last one, yeah, so this is an interesting one. So what's the next most appropriate intervention for this patient? So 40-year-old pedestrian struck by a car, brought in by ambulance at 12 p.m., so that's midday. In the emergency department, he's vomiting, has noisy breathing, signs of paradoxical chest movement, distended and guarding abdomen, mangled leg. Okay, so in the emergency department, he's vomiting. So that's not a good sign, maybe a sign of head injury. Anyway, vomiting people are a risk to their airway. Noisy breathing, okay, he's got features that suggest problems with his airway. Signs of paradoxical chest movement, that's basically a flail chest. Again, he's got respiratory compromise. Distended and guarding abdomen, so he's also got something that maybe necessitates a laparotomy at some point. And a mangled leg, so clearly something that we as orthopedic surgeons would want to manage as well. What's the next most appropriate step? As all of you know from ATLS, the next most appropriate step would be to secure his airway. And so the only way of doing that is to do a rapid sequence induction. And obviously you wouldn't do that, the anesthetist would, but you would be expected to know that. Yeah, so what the next most appropriate step is, because this is just an ATLS type question. Giving tranexamic acid and antibiotics, yes, definitely a good thing to do and definitely worth doing, but it's not the next most appropriate intervention or the next appropriate intervention. The biggest problem this patient has is his airway, and that needs securing. Invariably, he'll have to go to theatre for a laparotomy soon. Yeah, invariably, he'll need to have a CT scan. But, you know, if this guy's got airway compromise now, that needs to be assessed before going anywhere else. Thanks, Ruth. Shall I stop sharing?
Yeah, thank you. Thank you very much. So in terms of questions, if Siram is there, he's got the list of questions. But I'll start off. When is Haris Abdulwahid said, when is TEG appropriately introduced in resuscitation? Is it in the ED department or in ICU or in the theatre?
Yeah, so some places try and do it in the ED. I think most people, though, would use it in ICU or in theatres. It's not necessarily something that's happening in most ED straight away, but if someone does go up to theatre, it's happening during their damage control surgery, doing their laparotomy, their wound washout, it's happening there if they're actively coagulopathic and bleeding, etc., and definitely happening in intensive care. That's where it generally does happen.
It seems that most people, yeah, here we are. Osama Rashi is saying after 24 hours from the pelvic binder should be removed. Assuming the patient will need a few days to have the fixation, do you still apply an X-fix in that scenario?
No, so that's an interesting question, and there's some philosophical issues and beliefs around different trauma centers about what needs to happen with pelvises. Remember, the binder is a hemostatic agent, and that's why you should think about it, not as a mechanical device. There are definitely patients, typically with a lateral compression type injury. There are typically some patients, typically with a AP type injury, so like an APC2 or something like that, or even the APC3, who definitely feel better when they have a binder on, like they find themselves more comfortable. I've definitely had lots of awake, stable patients. In 24 hours, we want to take their binder off with an APC2 or 3 injury, and actually, we take it off and they're like, ooh, they start complaining that things doesn't feel right in their pelvis and in their lower back. And so they really like having the binder on as a comfort device. So, but really think about it as hemostatic device. So you take it off after 24 hours, clots are usually stabilized at that point, and you wouldn't necessarily need to routinely do an X-fix for those patients just because you then have to wait a few days to definitively fix them. The only thing you would do is continue your pelvic rolling restrictions in the interim. If you need to apply an X-fix to a pelvis, it would be in the situation where they're going to theatre from the emergency department, either because they're bleeding, exsanguinating from their pelvic injuries, or they may have an open pelvic injury, something with a rectal tear, etc., or a perineal laceration, that kind of thing, where you need to stabilize the pelvis. So those patients typically would be the ones getting X-fixed. No, we're not really doing X-fixes day 1 or 2 as an interim temporizing measure. I don't think that's really needed.
And so your talk is really good, Mr. Vasarady, and
just call me Ash, it's fine.
It's a very important topic, and we really do appreciate the time you're giving to us. But it's a testament to actually how well you did perform that talk. Nobody's really gotten too many questions because you covered a lot of areas really well. One of the questions that has come up is CT whole body scan. Do we just do it with hemodynamically stable patients as well?
So yeah, this is a very interesting question. So in the past, obviously, we all know the term donut of death. Yeah, so CT scan used to be the donut of death. It used to be called that in ATLS courses, but actually it's not. And really going to a CT scan, especially within a major trauma center, is definitely seen as part of the resuscitation, right? Because you cannot target and cannot treat effectively what you don't know, right? And clinical assessment is just not good enough. It's not accurate enough. So we recommend highly patients have a CT scan. For the exam answer, the BOSE guidelines, and NICE guidelines for major trauma all say that you need to have a head-to-toe CT scan of everything to really get an idea of the injuries. And in that way, you can get your list of injuries and reprioritize them, or the trauma team leader can reprioritize them, and then you can then manage them one at a time and just go through it, as opposed to kind of just finding the injuries as and when you randomly decide to find them. So yeah, I would advocate taking patients, even if they're hemodynamically unstable, but they're being actively resuscitated, to the CT scan and have the CT scan. And here at King's, we are often taking the whole trauma team to the CT scan with the patient. So we just carry on the emergency department stuff in the CT scanning room. We step outside for the minute it takes to do the scan, and then go back and carry on resuscitating them.
But then what about the patient who's had a polytrauma but is hemodynamically stable? You would still take them to the CT scan as a
no. So I guess we have most major trauma centers, not even us necessarily, but most major trauma centers have a very low threshold to CT scan everyone. So if the mechanism fits, unless people are effectively walking in without any significant injuries, most trauma patients are having a head-to-toe CT scan. Yeah. Especially the people being brought in by an ambulance with significant histories, significant mechanisms, and abnormal initial hemodynamic monitoring from the ambulance crews, they'll all get a CT scan. Even if they begin to stable out, they'll still get one, just to make sure there's nothing that they've missed.
Yeah. And in terms of, so I'm not sure if we're going to cover this in the VIPA section, but I'll ask this question anyway. Yeah. In terms of pelvic fractures where you have uncontrolled bleeding, at what stage do you decide to go between IR versus surgery and pelvic packing? So when radiotherapy room versus the...
Yeah, it's a great question. I was kind of touching on it later, but great question. Let me deal with it now, and then we can clarify it later if we need to. So the first thing to remember is that there are some general philosophical beliefs and institutional beliefs of how to manage pelvic fractures, okay? So if you were to go to North America, there is definitely a lot of trauma centers, really well-renowned trauma centers, that are really pro-pelvic packing, okay? So you already had a little bit of confirmation bias because one group has a tendency to do one thing regardless. And then there's another cohort who will say that, yes, you can think about IR, but the problem is out of hours, it'll take you like an hour to get the IR team in from home to set up the room. And then, it's just quicker to go to the surgery and fix it and fix everything and deal with it. So there's a number of competing issues. There are other things to then think about is, one, if you're going to IR only really works very well if it's selective, as in it's going after a named vessel, and that's usually a branch of the superior gluteal, for example. Yeah, you don't want IR to basically be taking out an entire internal iliac artery, right? That's just not a good thing because it causes muscle wasting. It leads to atrophy and tissue necrosis in certain areas, and actually that can then mean that as a pelvic surgeon, I can't go and surgically manage that area because the risk of infection then becomes ridiculously high. So there's issues around that. So it needs to be selective. So what some people say is, and a lot of trauma centers have a protocol for this, and I would strongly suggest for those of you seeing the exam, is to find the protocol for this at your major trauma center. If you work at a trauma unit, i.e. your DGH, you will have access to the major trauma center's policy on this within your own institution. And here at King's, it's like a little flow chart that tells you who goes where what. But generally, if you have someone who goes to a CT scan, and on the CT scan, there are signs of an arterial injury associated with the pelvic and/or acetabular fracture, and typically people talk about a little blush on the CT scan with an arterial injury, those patients are probably the ones that would do best to go from interventional radiology. Sometimes you find that actually, by the time you get to IR with your amazing resuscitation that you guys do in your hospitals, everything's sorted out. And then so you then end up with a little bit of a negative IR, and that's okay, all right? The other problem that happens is when you look at research studies that talk about pelvic packing and talk about IR, if you look at how their patients are managed in the emergency department in those hospitals that report on this, a lot of them, especially in North America, a lot of them are getting 2 liters of fluid, like 1 or 2 units of blood, and no blood products. So they're not getting any kind of what I'd call, what we're doing in the UK here, some really good resuscitation. And so that completely clouds the picture. So we can't really apply findings from American studies into UK practice because we're just slightly further along, I think, in the ED resuscitation, pre-hospital management than other centers. So overall, if you go CT scan, you find an arterial blush, think about IR, that's probably your answer. If you don't find a blush, then the bleeding's either going to be venous or from the bone, and then that's where your binder, tranexamic acid, and accurate resuscitation will help. You then look at the trend of the patient, and if they're getting better over the next couple of hours, then you're done. You don't need to do anything. If they're getting worse, and their lactate's getting worse, and actually they're needing more and more blood transfusion, more products, and their numbers aren't stabilizing, then yeah, they'll need to go somewhere, okay? And that will probably, in that case, be a theater. Is that okay? That's a long
perfect answer. No. It's absolutely a perfect answer. And then the examiners in this scenario will then push you to say, well, the patient's really unstable. Where do you choose to go? And it's always difficult.
And I think the safest answer would be that if you have an arterial injury in if you have an arterial injury identified on CT scan, you should then speak to the examiners and say, if you have access to interventional radiology, then yes, you would discuss it with them, and if they're happy, you'd take them to interventional radiology. But if it's not an arterial injury and it's kind of a general venous ooze and ongoing bleeding from the bones, then surgery is your best option. Sometimes you take them to surgery because, say, IR is not around or not available, and then you pack everything, it doesn't settle down, then sometimes you end up going back to interventional radiology after surgery to just fix any outstanding arterial injuries.
Yeah. And some centers IR in the same room, so they can do IR in the operating theatre as well.
Oh no, yeah, exactly. No, absolutely. There are some hospitals are blessed with a hybrid theatre where you can CT scan, IR, and operate all in the same place. But most of us aren't, sadly.
Where I work with, yeah. So
thank you. Yeah, thank you, Mr. Baderdi. Well done. Very excellent lecture. So now we'll stop recording and we'll go to the Viva.